Hello, I'm Professor Roald Flesland Havre.
And my name is Tom Pedersen.
We work at Haukeland University Hospital in Bergen, Norway, and we would like to give a short presentation of our study entitled Learning and Deskilling Effects of Artificial Intelligence in Colonoscopy among endoscopists with different levels of experience, a pragmatic prospective trial.
We conducted this study because we wanted to examine how artificial intelligence for polyp detection, CADe, influences polyp detection in a real-world setting among inexperienced and experienced endoscopists in different clinical settings. After the first promising studies that showed an increase in polyp detection, recent studies have questioned the effect in real life, and one study even showed a deskilling effect in experienced endoscopists when exposed to CADe. We included patients from a university hospital, a local hospital, and a private outpatient clinic. Each endoscopist included patients in 3 consecutive phases. First without CADe, then with CADe, and finally without CADe. In this way, we aim to assess polyp detection before, during, and after AI use. By comparing phase 1 to phase 2 and phase 1 to phase 3, we aim to evaluate the effect of CADe when used and whether there is a maintained learning or even deskilling effect after CADe use.
We have used the quality indicator PDR5 for polyp detection. This indicator is used by Gastronet, the quality registry of colonoscopy in Norway. PDR5 is the proportion of colonoscopists with at least one polyp sized 5 millimeters or more. In this study, we included more than 5,000 colonoscopies by 7 inexperienced and 6 experienced colonoscopists.
We performed multivariable analysis and found that the PDR5 increased significantly in the inexperienced endoscopist group from 31.9% to 39.5% when CADe was used. When comparing phase 1 to phase 3 among the inexperienced, there was a non-significant increase in PDR5 from 31.9% to 36.3%.
In contrast to the inexperienced, the experienced group had no effect on PDR5 when using CADe. Or when compared to phase 1 to phase 3, we could not detect any learning, but also important, no deskilling effect.
Overall, these results support a targeted deployment strategy for CADe, prioritizing its use among trainees and early career endoscopists, where a clear PDR5 benefit is observed. The added value for high-volume experienced endoscopists in real-world practice may be limited.
Additionally, the absence of observable post-exposure reduction in PDR5 compared with pre-exposure argues against the idea that exposure to CADe in itself reduces skills. Further research on human and artificial intelligence interaction is needed as the technology develops rapidly, and ESG has addressed this in the curriculum for safe and effective use of artificial intelligence in endoscopy.
So in conclusion, CADe increased PDR5 temporarily in inexperienced endoscopists, but did not have any significant impact among experienced endoscopists. No upskilling or deskilling was observed after CADe exposure.
We wish to thank Endoscopy with its editors, the reviewers, and the editorial team for accepting and improving our work. We would also like to thank the co-authors and our colleagues for their contributions.